And to introduce our speakers, I'd like to invite Dwayne David, a friend of the Carl Jung Society and the founder of the Society for the Exploration of Altered States, to speak a little bit about our presentation tonight. Thank you.
Thanks, Diana. Thank you to the Jung Society for inviting me to be here. And of course, thank you for esteemed guests, Michael and Annie Mithoefer. So glad you guys are here. Good evening, friends. My name is Dwayne David, and I am a friend of the Carl Jung Society and organizer of the Society for the Exploration of Altered States, or SEAS for short. I am thrilled and honored to be here for this momentous occasion, and I am grateful to the CGS board for inviting me to introduce Michael and Annie Mithoefer, a pair of brilliant therapists and researchers who are spearheading truly remarkable and life-altering research right here in the greater Charleston area. In 1973, the Mithoefers moved to the Low Country to attend the Medical University of South Carolina, with Michael earning his doctorate and Annie her nursing degree. After serving in emergency medicine for a decade, Michael accepted a residency in psychiatry, and some years later, the couple opened their own private practice. Fueled by personal interests in psychedelics and a passion to better serve psychiatric patients, they searched for possible avenues to resume therapeutic work with these compounds, even though all clinical use had been banned for quite some time. However, an opportunity unfolded during a fateful encounter with Rick Doblin, Executive Director of the Multidisciplinary Association for Psychedelic Studies, or MAPS, in March of 2000. Together, he and Michael began laying the groundwork for their first MDMA-assisted psychotherapy research protocol. 14 years have passed since they completed the first study, and now with the conclusion of the Phase 2 series, the FDA has given MAPS a breakthrough therapy status to expedite the upcoming Phase 3 trials, which are slated to begin later this year at 17 sites, 14 in the US, 2 in Canada, and 1 in Israel. Certainly, the need for this promising treatment is great, given the high prevalence of trauma and PTSD in South Carolina, the United States, and across the globe. For some of us, we may know the effects from our own personal experiences or via those of a loved one. As a community, Charleston has witnessed the violent deaths of Walter Scott, the mother Emanuel Nine, and more recently, the activist Muhyiddin Debaha, to name a few. For their family and friends, the grief and suffering evoked by their loss may take years to recover. In recent times, we are also reminded of the centuries of intergenerational trauma that continues to plague our brothers and sisters of the African diaspora, the Native American or First Nations, Latinx, Jewish, and LGBTQ+ communities, among others. And yet, the potential that MDMA-assisted psychotherapy has for the individual and collective to safely process trauma, drastically reduce the symptoms of PTSD, and bring about much-needed healing truly inspires hope. I first learned about Michael and Annie back in 2015 and was introduced by our mutual friend, Linda, the next year. I remember greeting them with nervous excitement while clutching a copy of their book, Acid Test, LSD, Ecstasy, and the Power to Heal. Deeply flattered that these internationally renowned researchers had accepted my invitation to meet. I also recall the time I met Flynn, their small terrier mix, who was fondly described by the couple as the best therapist in the building in a Post and Courier article. I had accepted a brief work assignment at their modest office, and upon my arrival, Flynn bounded from between Michael's legs, gave me a few quick sniffs, then looked back at him as if to say, "Yeah, he'll do." In that moment, I had received his most valued seal of approval. One thing I truly admire is their strong commitment towards building and healing community. For instance, they braved monsoon-like weather to be at the SEAS launch event in North Charleston, much to the excitement of the other attendees. During our first psychedelic integration circle in West Ashley, they humbly held space with Catherine McLean, a former Johns Hopkins psilocybin research, as the group recounted various experiences with altered states of consciousness while attempting to derive meaning from them. As psychedelic researchers, the Mithoefers are usually tasked with creating a safe therapeutic container for their clients by embodying presence, compassion, and empathy in the face of great suffering. In an act of mutual reciprocity, I strongly encourage everyone to work collectively to co-create a welcoming space for them as they share their experiences and insights acquired from engaging in such profound work. As we reflect on their words, I also ask each of us to be mindful of the numerous Native and Indigenous peoples, both past and present, who utilize psychedelic plant medicines and other substances for centuries, while bestowing vast boons of knowledge and wisdom upon us for many generations to come. Without them, none of this work would be possible. And so, my friends, the moment we've all been anticipating, please help me welcome to the stage my dear friends and mentors, Dr. Michael and Nurse Annie Mithoefer.
Thank you, Dwayne. And thanks for pointing out, we're operating under FDA investigational new drug permit, but thanks for pointing out that this class of drugs is definitely not a new thing, and many people in many cultures have known a lot about the healing potential of psychedelics for a long time. So we're picking up the thread in our culture now, but it definitely not something new. Also, thanks for pointing out that Flynn is the best therapist in the building. It's definitely true. And thanks for coming, everyone. We've never spoken in a room full of almost all old friends, so it feels very welcoming. You want to say anything?
Well, one little piece of information, we're going to go for about an hour, and then we're going to have the break, but then we're going to have another segment with a video, so that'll be another 40 minutes after the break.
So the plan is I'm going to show some slides to kind of give you an overview of where we are in the research and explain the protocols a bit and how we do it so that you'll understand the most interesting part, which is what happens in the sessions themselves that we're going to show you. So I'm going to go through the slides pretty quickly because we've published papers you can read about the details, and you can get our treatment manual and all our protocols are available on the sponsor's website free of charge. So I'm going to go pretty quickly through that part to make sure we have time for more focus on what happens in the sessions. And the way we're going to do that is Aaron Passo has graciously agreed to help us. At the end of this first session, we're going to read you a segment from one of the sessions, a verbatim transcript from one of the sessions so you can get an idea of that. And then we'll have time for discussion at the end of that before the break. Then after the break, we'll show a few more slides, and then we'll show a video of a veteran who has allowed us to use his actual video of some of his sessions. So we want to have time for discussion and questions at the end of each segment. So please hold most of your questions and discussion until then. But if there's something that really isn't clear, don't hesitate to raise your hand and ask. So, as Dwayne said, we've been doing this for about 18 years now, studying MDMA-assisted psychotherapy for PTSD, and our research is all sponsored by a private nonprofit, the Multidisciplinary Association for Psychedelic Studies, and they just finished raising $26 million for the phase 3 trial, so that's where the money comes from, donors. So this is MDMA. MDMA has been around for a long time. Merck originally patented it in 1914. They never did anything with it, but it's been off patent for many years. So that's why this is all sponsored by a nonprofit. And in fact, our sponsor has hired a patent attorney to make sure that neither we nor anyone else could get any use patents on it. So we want this to remain a nonprofit effort in the public domain. MDMA is often referred to as a psychedelic, which is technically true. If psychedelic means mind manifesting, I think that is a good description of what MDMA does, but it's quite different from classic psychedelics like LSD or psilocybin. So Dave Nichols, a chemist at Purdue, has suggested the term entactogen might be better, meaning to touch within, referring to the way MDMA tends to help people become more aware of their inner process, along with having more empathy for themselves and other people. And it says less perceived loss of control. That is true, but it's relative to classic psychedelics. In people with PTSD, sometimes there is quite a lot of fear of losing control, even with MDMA. A lot of you probably know, before MDMA was resynthesized by Alexander Shulgin in 1976, and then between the late 70s and 1985, MDMA didn't have any legal status, so it was not an approved drug, but it was not illegal either. So quite a number of psychiatrists and psychologists reported using MDMA in conjunction with psychotherapy. There was never any controlled research done, but there were published case reports. And these are some of the distinguished people who, including psychiatrists from UCLA and Harvard, who testified at the DEA hearings, which ended up, contrary to their advice, putting MDMA in Schedule I in 1985, which brought all legal use to a halt and made research very difficult. So you'll understand, when I talk about where we are in the research, just a quick little lesson on the FDA terms. Our sponsor basically is acting like a nonprofit drug company, going through all the FDA drug development phases. The first phase is preclinical work in animals and laboratory studies, and then phase 1 is the first time a drug is given to healthy volunteers to test pharmacology and physiology. So phase 1 trials had already been done. There had been 3 of those in the US by the time we started working on our trials in 2000 is when we started working on the protocol. So then phase 2, which is what we've been doing all this time, is when you give a drug to people with a diagnosis to test safety in a patient population and treatment effects. So that's what we've been doing. And those are, by design, fairly small studies because the FDA doesn't want you giving it to too many people until you've tested it more. And then where we're just embarking on now is phase 3, which is basically very similar to phase 2, but larger, bigger numbers in multiple sites. So as Dwayne said, well, we first started working on this in 2000. In November of 2001, we got our approval for our first study by FDA. It then took until early 2004 to get DEA approval. That's a long story, but we did get it. So that's when we started our first trial here in Charleston, and then we expanded. So, well, we enrolled the first person in April 2004. And so as of 2016, the sponsor has now done 6 phase 2 trials. We've done 2 in Charleston, and then we've trained therapy teams elsewhere to do the other trials in Colorado, Vancouver, Switzerland, and Israel. So based on those phase 2 results, we then went to FDA in 2017, and we got clearance to move on to phase 3 trials, which is the final phase before you get a drug approved. And as Dwayne said, we applied and they awarded us breakthrough therapy designation, which means based on our phase 2 results, they think this is a big enough advance for a life-threatening illness that they want to expedite it through the FDA process. So that's what we've been doing. This was after our first meeting with FDA. We've had 2 in-person meetings and a lot of conference calls. So MP16 is an open label lead-in to phase 3, and at the same sites. So these are the MP16, but also the phase 3 sites. So you can see there, all these sites, there are actually 2 sites in San Francisco and 2 in New York, so there are 15 in the US and Canada, and then there's 1 in Israel. So those are all up and running now, and we've trained all the therapists. There are 83 therapists working in these sites that we all went through our training, and then we're supervising them by video now as they start the study. So why study MDMA? Well, I guess lots of reasons, but basically, it's well recognized now. Even the FDA, even the VA has put out this statement that psychotherapy is the definitive treatment for PTSD, not psychopharmacology. There are 2 drugs approved for PTSD, Zoloft and Paxil, and they can help with symptoms, but the definitive treatment is therapy. But often therapy doesn't work. Probably in about half of the people still don't respond, and that means 2 to 4 million people a year in the US alone with PTSD that don't respond to existing treatments. So our thinking is, if therapy is the treatment rather than just drugs, what about if a drug could catalyze psychotherapy, since it doesn't work all the time? So that's really what we're doing. So it's much different. I don't think the DEA has ever encountered
The FDA.
the FDA has ever encountered a drug study like this, because we're not, this is why I need a co-therapist. We're not just doing a drug study, we're studying drug-assisted psychotherapy. And of course, the other reason is there's so much need. Dwayne mentioned a lot of populations that are in dire need of help with trauma. The FDA spends $17 billion a year on...
The VA.
Thank you. The VA, with all these abbreviations, you'd think I'd know them by now. The VA spends this much money per year on disability payments. And actually, the highest ranking psychiatrist in the military before she retired was General Lori Sutton, and she actually called us to ask us about our research, and she's been very supportive. So the need is great, and that's what we're trying to address it. So in order to understand the sessions you're going to be hearing about, this is a diagram of our, it's a little bit generic, but it's basically the way the studies work. So the first black line is, first there's careful informed consent, then there's medical and psychiatric screening by psychologists and physicians other than us. And then if people qualify, then they have that yellow-orange bar is the baseline evaluation. So an outside psychologist does baseline testing to determine symptom levels and other things before we start. Then the 3 green lines are the preparatory sessions. So once we've met people and done informed consent, then we meet with them 3 times for 90 minutes to prepare them for the experience, to get to know them, have them get to know us. And then the triangles are what we call experimental sessions. So they're either MDMA or placebo sessions. And sometimes it's inactive placebo, and sometimes it's low-dose MDMA. It's kind of an active placebo, depending on the study. But they're all double-blind, placebo-controlled studies. So after 3 prep sessions, then they come in. They come at 9:30 in the morning. They meet with us. And then we have at least an 8-hour therapy session in which they receive MDMA about 10 in the morning, and we stay until 5:30 at least. So they have an all-day session, then they spend the night in the clinic with the night attendant, and then we meet with them again the next morning. For the next green line is the first integration session. Follow-up sessions we call integration sessions, because they're designed to help people integrate this intense experience. So they have 1 integration session the next morning, then 2 more over the next month, and we also talk to them every day on the phone for a week after the session. And then a month later, they have the next experimental session. And whatever they got randomized to the first time, they also get the second time. So either MDMA or placebo, followed by the same follow-up, and then a month or 2, depending on the protocol, after the second experimental session, then they have outcome measures done again by the outside psychologist, and then we break the blind. If they got full dose the first 2 times, then they go on to that third triangle, another full dose session, but open label, followed by the same integration sessions. If they got placebo, then they can go back to the beginning and have 3 open label full dose sessions. So it's a crossover design where people got placebo eventually get active dose. And then we have follow-up at 2 months and then 1 year or more after that. So just in a nutshell, here's our first study. It was people with treatment-resistant PTSD. They had to have failed psychotherapy and medications. Most had failed a lot of both. The average duration of PTSD was 19.5 years in this cohort. And in a nutshell, here's what we found. This is the placebo group. The measurements are baseline, 4 days after the first session, 4 days after the second session, and 2 months after the second session. So this is the CAP score, which is the kind of gold standard. It stands for Clinician-Administered PTSD Scale. It's a standard, kind of gold standard for PTSD research. So 80, their mean score for this placebo group was just under 80, which is high. That's severe PTSD. And you can see they had a 22-point drop in the CAPS with the placebo, with the therapy alone, the same all-day sessions. It actually was quite helpful, but they still had, and that was actually a statistically significant change, even this small number of 8 people. But they still had significant PTSD. The cutoff for enrollment was 50, and they had a score of about 60. So that's the placebo group. Here's the MDMA group. You can see a much bigger drop even after 1 session, a total 55-point drop, which was a 33-point spread from placebo. And that was highly statistically significant, even in a small sample. Just to give you an idea of the significance of that, when Zoloft, the first drug, was approved by FDA, there was a little under 7-point spread from placebo, and they got approval for treating PTSD, and we have a 33-point spread. You can't really compare studies directly that way, but it gives you an idea of it's not a trivial change. So that was the original blinded part. Then, as I said, the people that got placebo could cross over and have MDMA, so that was called stage 2. And then they, they had all the same integration sessions, and 7 of the 8 people decided to go on to phase 2. One person had a very strong response to the therapy alone and decided she didn't need any MDMA. So here's what happened with those 7 people. The first point is their baseline CAPS. The second point is their CAPS after all the therapy with no MDMA. And here's what happens when we gave them MDMA. So they responded very robustly too. That was statistically significant. And just for comparison, the graph you saw before, that's the original line. So you can see they both ended up in the same, both groups ended up in the same place once they got MDMA. So that was, we thought that was a promising start. But of course, one problem with this compound is it's hard to maintain the blind for very long. Usually people can guess what they got, and usually we can guess. Not always, but most of the time. So that's a challenge, but one way to address that is we decided, well, let's do a long-term follow-up a year or more later. And it turned out it was a separate study, so it ended up being an average of 3.5 years later. And we've published this in Journal of Psychopharmacology as well. So what happened was, so you'll understand the numbers, because that one person didn't cross over, we ended up with 19 people who had gotten MDMA. So there was no control group at the long-term follow-up. But here's what we saw. The first bar is their baseline CAP score. The second bar is 2 months after the last MDMA session. And the third bar is 3.5 years after the last MDMA session. Within that third group, 2 people did relapse to scores over 50, but they're included in that data. So if anything, the other people had a trend toward further improvement. So that also seemed very promising, because usually placebo effect doesn't last 3.5 years, as far as I'm aware. But one caveat is, so that means 88% of those people that took the caps had sustained benefit, but we only got the caps on 3 people. One person had moved and we couldn't find her, the other 2 didn't want to do it.
No, only 3 people we didn't get the caps.
I'm sorry, 3 people we didn't get the
Yeah.
caps on.
Yeah.
Luckily, yeah, not the other way around. But even if you assume they all relapse, which actually they told us they didn't, but we can't prove that. But still, that's a 74% sustained benefit 17 to 72 months later. So that was also very encouraging, but this was mostly crime-related PTSD, mostly rape and childhood sexual abuse. So we thought it would be good to study veterans and first responders. So our next study was limited to veterans, firefighters, and police officers. And in this study, we used 3 different doses of MDMA to see if we could find a dose that would be a good active placebo and fool us but not work. So we gave 30, 75, or 125 milligrams. And we did, the CAPS was our primary outcome measure again, but we also did some other measures to try to capture some of the other things people had told us. And so I'm going to just go quickly through it. This was the CAPS. The 30 milligram is blue, 125 is yellow, and 75 is red. So you can see both 75 and 125 were much more effective than 30. In the same range as originally. And to our surprise, except for Annie, Annie was not surprised, she predicted it, but the rest of us were surprised that 75 worked better than 125, at least in this sample, but they were both very effective. We also did, let's see, did I not have that on there? Yeah. Okay. Oh, yeah. Okay. Yeah. This was statistically significant. That's what that slide is showing you. So we also did depression scores, and you can see quite a lot of improvement in the active doses, not in the low dose. And importantly, looking at individual data, nobody's depression scores got worse. If they were high, they came down. If they were low, they stayed low. So any idea that MDMA was, people were running out of serotonin and getting depressed was not borne out by this data. Sleep got better. Lower is better on this scale, so the active doses had improvement in sleep. With some people, it was very dramatic. We're sleeping through the night with nothing after having used lots of things before. And then we also measured post-traumatic growth, and that was a lot of post-traumatic growth with the active doses, not with the low dose. So, as I said, now we've finished 6 phase 2 trials altogether, and 2 of them have been in Charleston. We've published the first one in Charleston, the one in Switzerland, and then we just, our paper about the veteran study was just accepted by Lancet Psychiatry about 10 days ago. It'll be published at the end of this month. And the other studies people are working on the papers. And so the data pooled from those 6 studies. So it was 5 different sites in 3 different countries, 6 studies. And this is a little confusing, maybe, but the little blue line is the comparator dose, which was either low-dose MDMA or placebo, and the orange-red line is the active doses of MDMA. So you can see there was a big drop in pooled data, and then the point way out to the right, the white line in the middle is the comparator group. It's discontinuous because then they later went back and had MDMA and they had a similar drop. And then the final square is the long-term follow-up 1 year or more later. So the pooled effect size was 0.9 across studies. In some studies it was over 2, but pooled was still a large effect size. So this is the data that the FDA used not our analysis or our graphs, but our raw data. When they analyzed it themselves, they decided they'd give us breakthrough designation. So a few other things we've done. We recently completed a couple study with collaborating with researchers from Toronto, Candace Monson and Wagner. We combined Candace's method of cognitive behavioral conjoint therapy, working with couples, and we embedded 2 MDMA sessions in that course of therapy. Candace and Ann flew down from Toronto every couple of weeks to do the sessions with us here. And that was a very small pilot, but it was very successful. So we're hoping they're going to do more of that. Yeah. Also, June McDaniel, I don't think she's here tonight, but she's a professor at the College of Charleston. She used some of our data to analyze some religious study type of things from our outcome data. We collaborated with Mark George and Diane Hanlon on an imaging study with the veterans at MUSC, and we're waiting to get their analysis of that data.
Colleen. Colleen.
What did I say?
Diane.
Oh, Diane, yeah. Diane Hamrick was not doing that, but she's here. Colleen Hanlon, yeah, thanks. Let's see. Well, and an ongoing protocol that we've had open for about 5 years now is we have permission from FDA and DEA and the IRB to give, it's a phase 1 trial, but therapists who have been through our training program and are going to work in research can have their own MDMA session with us legally. So we've done a little over 20 of those so far, and then we opened a site in Colorado a couple of years ago, so there's therapists out there are doing that too, because we think it's really, really good if the therapists can have their own experience. So I think maybe we better stop there on the slides. And Erin Passo, who many of you know, and who's a local psychologist and a phase 3 MAPS therapist, is going to help us read a segment of a MDMA session with one of the veterans. Do you want to share this one? Either one.
We can share this.
All right.
At first,
Cool.
I'll talk more. So we're going to do a segment that was a participant named Rachel. We changed her name for this. Rachel was a 38-year-old woman that was a truck driver in Iraq. She also carried a weapon. One of the things that bothered her the most was when the truck was stuck on a bridge, and they didn't know what was happening ahead. They were stuck there for quite a while, and suddenly they were surrounded by kids, and she had to beat them off the truck with a stick. And she threatened, but she motioned and she yelled at them, and this was particularly difficult for her because she'd had a traumatic childhood. And so the idea that she was doing something to kids was really hard. She couldn't look at little kids anymore. That was part of some of her PTSD symptoms. She had a CAPS of 105 when she started, and after her 2-month follow-up, it was 54, and then at her 1-year follow-up, it was 87. So I think this demonstrates how it catalyzes, the MDMA catalyzed her process, and she kept working through things. And frequently people will go through bumps in the road and then continue to do better. And so we've been in contact with her, and she's really gotten significantly better. So Michael, do you want to?
Yeah, so we had the opportunity a month ago to do a day-long workshop at the San Francisco Jung Institute, and we showed about 3 hours of video there, and we sent one of the, Amy Weston, one of the Jungian analysts there, was the discussant, so we sent her the video a month ahead of time, and she had a chance to look at it and then make her comments. So Annie's going to read some of Amy's comments because we wanted to bring in the Jungian's perspective. And so we'll read those first, and then you can sort of think about them as you're hearing the script.
So this is what Amy Weston said. Rachel, as a soldier in war, especially one suffering from childhood trauma, is particularly vulnerable. In the war situation, the training as a soldier to be a sanctioned killer promotes a dehumanization of the enemy and a place of humanity only in the protection of one's fellow soldiers. In addition, in these wars, the larger, more noble purposes of past wars is not available to many combat veterans. She is less successful at dehumanizing the enemy, especially when they are children, paid money for food to plant IEDs, unimaginably conflictual. So she is left at the mercy of her own defenses, identifying with the evil she first learned was her essence from childhood abuse, and later fueled by the need for these defenses to keep any goodness safe from being destroyed by her badness. So we have her poignant discussion of keeping the birds safe from herself. So Erin is going to be Rachel, and Michael and I are going to be the therapists.
It's not a headache, it's tension. It's different than a headache.
Yeah, so it's really good to stay with all of this.
It's right there like a rock.
So just letting the medicine in your inner healer help you with this.
It's all the padlocks I put in Iraq. They're heavy on my head.
So if there's any energy, squeezing, it might be good to hold Michael's hand too, just to release and breathe into the energy of all that anger.
Padlocks, all those feelings.
If you feel like it, we can provide resistance with our hands, and you can push up against our hands or push up.
I don't want to unlock it though.
It's good to unlock it in a safe way. This is a safe way to unlock it. No one's going to get hurt this way.
I don't know.
Feeling how heavy those padlocks are.
They're so heavy, they're so heavy.
Yeah.
It's the heaviest thing I've ever carried.
Yes, absolutely.
But it's got to stay locked.
Why does it have to stay locked? What if you could safely let it out and process it?
What if you could trust us that we can help you with it?
I don't know.
So just take your time with it. Stay with it and see what's needed. Trusting your inner healer.
There's a smaller lock too. I could maybe go into that smaller lock. I can't go into the bigger one. I don't know what's behind the smaller one either.
So how about just letting that padlock release a little bit?
I feel like it's not an easy process because I have to stick the key into the lock and then unlock it, then slowly lift the lock off, and then slowly open the door.
Okay, so take your time. We're right here with you.
I just don't know what's on the other side of the door. I mean, it's the smaller lock, but I don't know what's on the other side. It wants to open, but I don't think I want to open it. I don't know what's back there. I don't know. It's kind of creeping open itself. I don't know. It's bright. Whatever it is, it's bright.
Yeah, so just breathing into it. So then she went on to have, actually the brightness was the sun in Iraq, and she went on to actually have some really happy memories of Iraq under a hose in the motor pool cooling off with her friends. So I wonder why these memories are behind the lock.
Oh yeah, because these are good memories. I even have the good memories behind the lock.
I think that happens a lot.
I guess because if I have the good memories, I have to recognize the bad ones too, But I like some of my good memories. I guess the problem is that opening the smaller door weakened the bigger door, but it's really bad inside. It's like pushing up against the door.
Well, one thing that's true is whatever is there is already something you're carrying around and it's affecting you.
It's beating on the door.
And I trust your inner healer to decide whether you can go there. But it is true that it's already affecting you, and we're here to support you in whatever you need to do.
It's such a big door.
So take your time and see what's needed.
But the good memories are already out, so there's nothing good left.
How do you know? You didn't know what was behind that little lock.
Yeah, I didn't know what was back there, but there's nothing but bad stuff back behind that big door.
Well, the reason for letting it out in a safe way and processing it is to bring healing to it.
I know, and I want to do that here because I don't want it to come up anymore anywhere else.
Yes, I think that's very wise.
Because I'm always afraid of the rage. I'll rage out.
Right, yes. I think that's exactly true, that doing it here actually frees you from being afraid of it bursting out. So then she went on to have images of when she was having to threaten the children and get them off the truck.
They just have nothing, and it's scary because whoever it is that's fighting us goes up to these poor people, and it's like, plant this IED, and I'll give you money. Well, of course they're going to take it. They have nothing, you know? It means feeding their kids. Shit, I accidentally crawled under the door. I'm on the lock side now.
Okay, we're here with you.
I don't want to be on this side.
So what can we do to make it safe?
I need to get out. Can one of you unlock the door, please? Because I don't want to be here.
Yeah, I'm unlocking the door and letting you out.
Thank you. Thanks for unlocking it.
Yeah, we're here to help you process this in a safe way.
That was really funny. Like, it's not like you really did anything. Michael, it's just like, I'm unlocking the door. It's not like you really did anything. But seriously, it's like working.
I'm glad it helped. I'm glad it worked. I think there's a little bit of control that you didn't know you had.
I just need to lean up against the door for a minute and catch my breath.
So she rested for a little bit and she talked a little more about some of the positive things with her friends in Iraq.
I got sucked back in on the other side of the door.
You're back on the other side of the door?
Yeah, it's really dark.
So what if we come and be beside you there?
I'd like that because I'm scared it's really dark and I don't want to be on the other side of the door. It has locks on it for reasons.
I'm willing to be there with you.
Me too, Rachel. What would be good at this point?
Just stand next to me.
Yeah.
Yeah.
You know, it has locks for a reason, but also you're exploring what's in there for a reason, too. It needs healing.
Can I hold your hand?
Yeah.
We're right here with you.
It's just really dark and there are like things flying around, like something goes by and it's like screaming and then flies off.
Can you tell what it is that's flying off?
No, it's just screaming incoherently and then flying off. And then there's like a bunch of things flying around screaming.
Screaming human voices?
Yeah, it's probably my voice.
Uh-huh.
I want to grab one of those like lacrosse nets and like catch one to find out what the fuck is in here. Because the door seemed like it was pounding open earlier. I thought it was just Iraq behind this door. I don't know what's behind it here, but it seems like there's more. I don't know.
So take your time with it. We're right here. We're not going anywhere.
See what you can discover.
Okay, I caught one. It's yellow and it's screaming. It's yellow and it's screaming like it's a bird, feathers. I don't know. I've got to peel it apart. What the fuck bird things are flying around in my brain? Maybe it's not so scary because it's just completely ridiculous. That's probably more accurate. I unwrapped the bird thing and just a puff of smoke came out and that's it. What the fuckity fuck? Well, I was going to throw it away, but the bird looks hurt.
Maybe it needs healing.
I probably shouldn't have tugged at it so hard. It says I don't have to rip him apart.
What is needed?
Attention. He wants to fly around happy, not be in a tight ball screaming.
So it needs attention from you?
Yeah, it wants to like fly around like a regular bird, but just wants to leave now. It doesn't want to talk to me. It just wants to leave since I unballed it.
Where does it want to go?
It just wants to fly off and be free.
Would it be okay to open the door?
And let it out?
Well, I'm just wondering. I don't know.
Yeah, it'd probably like to be let out and not be in the dark anymore.
Would that be okay with you?
Yeah, it seems like a nice bird.
Yeah, great.
I don't know if I should come out too or if I should just let the bird out.
Well, just check and see.
I think I need to come out with the bird.
Okay, great.
It's so much better not being in there. The bird is really pretty. In the light, it looks really pretty.
It's yellow?
Yeah, really sparkly. It has this turquoise thing that comes out of its head. Like I've seen in pictures. Now that it's out of the dark room, it doesn't really want to fly away necessarily. It just wanted to be out of that room.
Yeah, great. Does it still want some attention from you?
Yeah, it wants to be petted. It's just a pretty bird.
Are you petting it?
Yeah. I know this sounds really ridiculous.
Not to me.
Me either.
Oh, it's just so pretty. I didn't know there could be anything pretty inside of me. But there's this pretty bird, and it's so beautiful.
There are beautiful things inside of you. I'm glad you got to see that.
And I keep them all locked up behind a big door with a big lock on it, so I forget about them. I forget about this pretty bird. I don't know what this pretty bird represents necessarily, but it's just, that's what I keep locked up behind that door. All the things that say I'm a nice person, all the pretty things, I keep them locked up.
Yes, that's what happens sometimes when we get really afraid or traumatized. Out of fear, we do that.
I didn't want them to leave me. I thought that the birds would leave me, so I kept them locked up.
They didn't want to leave at all, did they?
It just wants to be out of that dark room.
I'm so glad you can let him out.
You don't have to do that anymore.
I was just always afraid of it. I don't want the birds to fly away. I just thought if they were locked up, at least I still had them, because I was afraid if I let them out, then those good parts would be infected by everything else.
Yeah.
It was toxic out there. No wonder you kept them locked up.
The bird showed me oil didn't stick to its feathers. The sludge doesn't. Well, maybe this one bird.
Resilient?
But other birds maybe.
Or maybe not.
He wants to let some of his bird friends out.
Is that okay?
Well, I don't want him to be lonely, but I don't know.
Just take your time and see what's right.
What if all the birds try flying out?
What would you be concerned would happen?
I would feel good because the birds are like little beacons to show me that they're good parts.
Beautiful.
Sometimes you have to take a chance, you know.
You know, it really is true with beautiful parts of who we are, that oil does run off their feathers.
But if I keep them locked up, they'll be safe, you know? There's a part of me that hates me so much that I'll just grab the little birdies and snap their necks, and I don't want them to get hurt.
So should we check in with that part of you that hates you so much and see what it may need? And that's what we did. So we got to meet a very angry, self-punishing part of herself that we worked with a lot, and it was challenging and took quite a long time, but it ended up being extremely helpful.
A really angry part that actually saved her life in Iraq, too.
Yeah, it would keep her awake and keep her from sleeping because it was always hypervigilant and on guard. And it didn't like us messing with the system. It said, "You think you're so smart, fucking smart, asswipe. I'm never going to let her get better." That was how I started my relationship with that part. But it did get better over time, but not that quickly. So that gives you a little bit of a flavor for the kind of archetypal imagery that can come up, which we always thought that sounds Jungian. So thank you. Thanks, Erin.
You want to stay up here?
Thanks a lot. Don't forget to de-roll.
Yeah, right.
So we have a few minutes before the break. If anybody has any questions or comments, we've got a few minutes before we take a break. Yeah.
What do you mean by post-traumatic growth?
Well, it's the idea that if you are able to really engage in healing trauma in a deep way, that process does more than just get you back to where you would have been without the trauma. There's a lot of internal growth that can happen as a result of having to go through that very painful and difficult process. So Paul Tedeschi, the psychologist, developed this post-traumatic growth inventory. And I think this is, I talked to him, he's from Charlotte. This is the first time it's ever been used like that. This is a before and after outcome study. So seems to be applicable.
And, you know, one way it shows up is people will start talking with other veterans about what happened to them, and there are many ways that people start using the trauma and what they've been through and advocating or doing other things that might help them too.
Were many of your subjects word of mouth, or did it sort of spread that way?
Were many what?
Of your patients, like word of mouth with these trials? Were they, how did you find your patients for the
How do we find them? You know, in the first study, we were referred by a few psychologists, and then a lot of them were self-referred. And then in the second study, a lot of them were self-referred. The veterans, one time I was doing a phone screening with a young man who was from another state, and I asked him how he found out about the study, and he said, "Ma'am, every veteran knows about your study." So the veterans are very communicative about what can help, you know, and looking for things that might help.
More than 1,000 people contacted us about that study for 26 people. And now more than 20,000 people have contacted MAPS wanting to know about when the phase 3 starts before we even started recruiting. So the recruiting was a bit slow for the first study, but it hasn't been since then. Yeah.
Yeah.
What are the negative possible symptoms of MDMA therapy, contrasted with that of current medicinal psychiatric treatments such as Zoloft?
What are the negative side effects of MDMA therapy?
Yeah,
if
well,
any?
certainly there are side effects of any drug, including MDMA, we didn't have time to go into that in detail today, but the main side effects, medical side effects of MDMA are cardiovascular. That increases pulse and blood pressure significantly. And so we do careful screening. We do not include people with underlying cardiovascular disease.
But in the second study, we were able to include people with hypertension, controlled hypertension. So because people did all right and we were taking blood pressure often.
It has acute side effects, like people get jaw tension. They often feel tired and washed out the next day, things like that. You know, in recreational settings, there's been problems with heat stroke and either underhydration or brain edema from overhydration, trying to prevent underhydration. None of that really applies to this setting because we make sure people they're not dancing all night and they're drinking a reasonable amount of liquid. So the psychological side effects are also something to really keep in mind. That's why we have so much attention given to preparation and integration, because MDMA can really stir things up and people can feel worse before they feel better. So they need to be prepared for that, and they need to have support. You know, I've had people in my clinical practice where I'm not using MDMA who have taken, with PTSD, have taken ecstasy at a party, and suddenly things about their trauma starts coming up and they're not prepared for it, they have no support, and they're supposed to be having fun, and that can really be problematic. So without the proper preparation and support, the psychiatric complications can be a problem. Yeah.
So would you say that the negative symptoms are worse than that of what is on the commercial market now, or because it's a risk-benefit payoff, you know, improve prescribing medicine, and if so, could microdosing help alleviate the negative symptoms?
Well, you know, I think the MDMA does have a favorable risk-benefit ratio so far. We're going to try to prove that more definitively in phase 3. I don't know how to compare it. It has different side effects than, say, Zoloft. One of the advantages of our model is that they only take it 3 times at monthly intervals. So even though it has side effects, it has the advantage of it's not something you're taking every day.
You know, and it's a different approach. Zoloft is you're taking it to reduce symptoms. This approach is getting at what's causing the symptoms. And it's just like any other deep PTSD therapy. If you did prolonged exposure or cognitive behavioral therapy where you were really getting to the root of what is happening, you're going to expect to have some turmoil for at least the week after with any of those therapies, because they're finally talking about things.
Yeah, there's a psychiatrist, George Greer, who was in Santa Fe, who was using MDMA back when it was legal, and he said, there's nothing you can do with MDMA that you can't do without MDMA. You just might not get to it in this lifetime. And I don't know about microdosing. You know, it's a different model because, again, we're using it as an intense process to catalyze a psychological process that's therapeutic, and that leads to healing the underlying problem as opposed to taking something every day. But I don't know about MDMA microdosing. Yeah, Dwayne.
Just more like a disclaimer, even though I imagine a lot of folks are aware of that, but there's still that misconception, I think, in mainstream of ecstasy and MDMA. I don't know if you can, I know in the past, kind of Maps has drawn the distinctions between the two, but I just wonder if you can touch base.
Yeah, well, thanks, Dwayne. That's one of the many reasons why you can't extrapolate from the safety profile in this careful research setting with pure MDMA to other settings. And the last report I read last year from DEA was they said only 18% of the Molly or ecstasy that they confiscated had any MDMA in it at all. So you don't know what you're getting. Maybe
there was a
one more, I
question in
think
the back.
somebody.
How has your experience been navigating the regulatory space with the FDA and the DA? Has that changed over the 18 years that this has been going on?
Yeah, well, the FDA we've never had a problem with. They're rigorous, but we got permission for our first study in 30 days after one, 500-page submission and one conference call. The DEA took 3.5 years, so that was a big problem in the beginning. But since then, once we got our first study approved by DEA, we haven't had any problems since. Now we've done a lot of studies, and it's much more difficult than to do research with the Schedule I compound because you have the whole DEA, and then it has to go back to the FDA-controlled substance division again. It's not quick, but we've not had any undue delays since we got that first study approved. Yeah, Diane.
Have you found that your subjects have had diminution in their substance use or abuse during the course of their participation in this therapy?
We have, yeah. People have to be free of meeting criteria for substance use disorder for 60 days before enrolling, but still a lot of people had been drinking a fair amount and smoking pot. Was
A lot of the veterans
very
had
frequent with the
were
veterans.
smoking pot
They
for
had
sleep.
to stop all that, but then they reported that they just didn't go back to it in any nearly the way they had. One veteran actually who was randomized to 75 milligrams, at the end of his one session, he told us, well, I wasn't really being honest with you or myself about my prescription opiate use. We knew he was taking prescription opiates because he'd been blown out of a truck and had a back injury. But he said, I realized in the session that I was using it to make myself feel better emotionally, and the message I got, the understanding I got was I don't need anything from outside of myself to change the way I feel, and that includes MDMA. So I don't want any more MDMA sessions, thank you. I will stay in the study and do the outcome measures. So he had one session with 75, did the 2-month and the 1-year outcome measures. His PTSD was gone. His CAPS was, way below 10 at 2 months and 1 year. So there's an anecdotal report. And actually a friend, Ben Sessa, a psychiatrist in England, has funding and is about to start a study with MDMA for people with alcohol abuse. So I think it's very promising for that.
I think we should stop, honey.
Okay, one more and then we're going to stop, even though I said one more a while ago.
We'll have
Yeah.
more questions at the end, too. But, yeah.
So in the session typically, do you have the patient that you just discussed kind of a more compartmentalized sections of her identity and her trauma where, as you said, she had a really strong reaction to you, that seemingly in kind of distinct personalities, I'm not sure. Like as they're processing their trauma through these sessions, what exactly does that look like? Was that a typical session for you guys?
Well, you're going to see one that's a little bit different in the video, but I'd say that there was a little more, that was more challenging, probably because of her not having had a family, really. She was raised by her mom, and it was a pretty abusive childhood. So for her, when she went in the Army, she actually was having a really wonderful time in the Army until she was sent to Iraq. And then it started coming up against compassion for others. And yeah, so, I mean, hers was bumpier, but they're always different. Yeah.
Yeah, and she, you know, we excluded people that met criteria for dissociative identity disorder, but we had people with pretty high levels of dissociation. Short of that, this person, once we got in the session with her, she would have met criteria for DID, actually, but it worked out. So she was pretty extreme in having such an intense part. You'll see in the video after the break, you know, we think that multiplicity is a normal phenomenon in the psyche. I'm trained in internal family systems therapy. So you'll see that the veteran you're going to see after the break becomes aware of different parts of himself, but it's a much different thing and actually really helpful, not as difficult to work with as that one was. She was on the difficult end. Yeah. Okay, I think we better 10-minute break.
Yep.